Sir, we are good to go now.
Yeah, a very good evening, good morning, and good afternoon to all the ladies and gentlemen, all the delegates who have logged in not only from India but across the world for this exciting evening webinar, which is brought to you by Mumbai Hematology Group and supported by Intas and other companies. I am Ashish Shah from Intas Pharmaceuticals Limited, and we welcome you all to this exciting webinar on MDS, the good, bad, and ugly. And also, the second topic is quite interesting, which is on chronic immune thrombocytopenia in pediatrics. This webinar is brought to you by Mumbai Hematology Group under the uh, mentorship, the leadership, and guidance of our program director and our moderator, who needs no introduction. But yes, for the sake of the new joinees, the few students who have logged in for the first time, it's important to know Sir and get inspired. Professor Dr. M.B. Agarwal, sir, Professor and Head of Department of Hematology, Bombay Hospital, Mumbai, 4 decades shaping hematology practice, education, and professional bodies in India and abroad. Sir is the president of Mumbai Hematology Group and past president of Indian Society of Hematology and the counselor of Soho representing India and fellow of College of Hematologists of Sri Lanka. Next slide, please. Sir received the Lifetime Achievement Award by Indian Society of Hematology and Blood Transfusion, and to his credit are 120 plus original articles published in national and international journals over 40 years, 25 orations to his credit, plus numerous national and international awards. His Sir's contribution to the field of hematology education is immense and it's countless. Sir has published a yearbook named Hematology Today annually from 2005 and 2018. And we remember every student in the field of hematology was up for this book, and it was flowing out of the shelf very quickly. So this book was such in demand those days. Sir is the global advisor for Thalassemia International Federation and Thalassemia Society, Maldives. Um, Now, without wasting a lot of time, I would request Sir to take over the proceedings.
Thank you, Mr. Ashish, for those kind words. Good evening to one and all. Today, we have got two speakers, Surgeon Commander V.A. Arun from Mumbai and Dr. Neeta Radhakrishnan from Noida. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS, managed by Perfect Square. Thankful to Dr. Manoj Kumar, Mr. Arun Hegde, Mr. Anis and team from INTAS, Mr. Yash, Mr. Kalpesh and team Perfect Square, Executive Committee of Mumbai Hematology Group, a guest speaker, Surgeon Commander Dr. V.A. Arun, Mumbai, and Dr. Neeta Radhakrishnan from Noida. All our discussants were themselves eminent clinical hematologists, medical oncologists, and pediatric hemato-oncologists. You participants, of course, for sparing your Thursday evening. Next Thursday, 30th of July, 6:30, we have Dr. Aditya Jandial from PGI Chandigarh speaking to us on the hot subject, bispecific antibodies in relapsed myeloma, current landscape, future directions. And then from Melbourne, Australia, we have Dr. Ashish Bajal speaking to us on CAR T cell therapy in ALL, and that will be at 7:30 p.m. IST. Few words about Surgeon Commander Dr. Arun V.A. He is Associate Professor of Medicine and Clinical Hematologist at INHS Aswini, Kolaba, Mumbai. He is MBBS, MD General Medicine, DM Clinical Hematology. He represented Indian under-16 cricket team 25 years ago, that is 2001 and 2. This was from Kerala, and also represented Ranji Trophy team, Kerala in 2003. I'm not aware of any other hematologist with this achievement. Publications, 44, might be more than 50 by now. Awards and felicitation, President's Gold Medal, Best MBBS Cadet, AFMC 2007, MUHS Topper, First MBBS, Second MBBS, Third MBBS, First in Grading Exam MD Medicine, Associate Fellow NAMS 2022. Brilliant career, brilliant achievements. Best Research Paper Award by Hematocon 2018, SIDSCON 2017, IBM FS 22. So papers after papers being selected as the best paper. Winner, National Hematology Quiz, Clinical Infectious Disease Society Quiz, Epicon 2016. Real all-rounder. Today he will tell us everything about myelodysplastic syndrome, the good ones, the bad ones, and the ugly ones. I'll stop here, give the platform to him to speak now.
I think is the presentation visible in the slideshow mode now? Could you just confirm?
Yes, yes.
Yeah. Thank you, sir. Thank you for those kind words. It's a dream come true when you introduce, I would say, a novitiate like us, because we have learned, everything in hematology and beyond hematology from the way you have, practiced hematology and practiced medicine and the way you carry yourselves on and off the field of medicine. So it's like, a humbling experience, and to be introduced by you, it's a dream come true. And, we have been having this academic session one after other for quite some time. And I've been part of this. This is my third presentation in MHG for in the webinar platform. So I'm really grateful to sir for having given me an opportunity to discuss this topic with you. Let me just know my slide. Yeah. So the only disclosure which I have is, when we have a very limited attention span, and, and the time span to discuss a topic of this magnitude, it's not easy. I have tried to cover up this topic, with these three chapters, because sometimes you're not fascinated by the Quentin Tarantino movies, because that's the way it evolves. So what I've done is, we move from learning, where I would bring in the evidence base and maybe finish it off in the first 5-10 minutes. That's what is available on for all of us to read. And sometimes it's not difficult to deliver all the goods to the patient. So that's where the critical appraisal or the unlearning comes. And maybe the last chapter is about relearning, and that's the Indian context. So all of us know what a prelude is. And with that, I think I've just discussed the global verdict for MDS, because that's what we should know and understand before we deep dive into that. So one, concept which has evolved is this transition from the term myelodysplastic syndrome to myelodysplastic neoplasm. So that is not too late, I would say, as recent as 2022, where we wanted to, tell everyone that this is not a sinister kind of a, this is in fact a sinister kind of diagnosis. It's no longer a syndrome. And when you say myelodysplastic neoplasm, it has a different connect. In terms of the prevalence, this is a beautiful paper in the American Journal of Hematology this year, and it talks about the burden of MDS and MPN. It spans across the world, but with some limitations of registry-based data and the lack of it in countries including us. But it does say that it's a rare entity, but it's not so rare. You say something as rare because it falls below 1 in 10 to the power of 5, but it's not so uncommon. In terms of hematological malignancies, it's more common than maybe myeloma and ALL combined. But definitely in India, you talk about CML and AML. MDS, the true MDSs are usually not picked up sometime because of their low risk nature. All of us know the clinical syndrome of MDS is defined by these two problems: the cytopenias, which actually brings the patient to us. Today, with the advent of Coulter report, you have patient thrashing and thrusting those reports onto you, and you have to, do that jigsaw puzzle. And some of them, inadvertently, because of bad cytogenetics and biology, or maybe late presentation, come to us with an AML transformation. Even with the best of, the advances, at least the high risk MDSs have not done well. That's when you say the 5-year survival, is between 20 to 50%. And risk adapted therapy, that's what we are going to discuss, is the way forward. And let me put it in the first slide itself. Like when we have MDSs, the only curative option as on date remains the allogenic stem cell transplant. So if you see the evidence base, this is what, the NCCN does every year. There is a group of, interesting, the best in the field. They meet up for a cup of coffee over days, and then, they come out with these beautiful guidelines. And, at least I think it's very important to have them in paper and print. Some of the, less fortunate, like our country, doesn't have it in print. Some of us have, eminence-based and I would say economics-based medicine to practice, but I think it's always best to have it in print. So if you see, this is actually the algorithm for management of lower risk disease. You don't have to mug up all this because we will dissect it out. And when you talk about lower risk disease, and especially one of the biggest problem has been anemia, you can broadly subdivide them into these two subsets, smaller subsets, which has this 5q deletion and the ring sideroblasts, and a large subset which are not cytogenetically defined. This is the largest subset of lower risk MDSs, and that is where what we end up using is sometimes erythropoietin, or in people who have access even luspatercept. When it comes to high risk MDS, the opinion is fairly clear. Somebody who's a transplant candidate and is eligible must go in for a transplant. You see some of these guidelines, have not picked up. You see the American guidelines or the NCCN were as contemporary as 26. The ESMO is 2020. I would say they don't differ much, although there are some recent advances which have been added to the ESMO, I would say. But overall, these are easily downloadable and you can access them. And if you see the British Society of Hematology guidelines, which came in 2021, they have a docket on evaluation of prognosis, and then there is a separate one on the management. More or less, you would see they are in alignment. When you have a lower intermediate risk, it is EPO or luspatercept or lenalidomide. And in some subset of hypoplastic MDS, there is a role of immunosuppression with ATG and cyclosporin. And there are, even you have a higher risk, even the British guidelines talk about transplant eligible and ineligible subset. So if I sum it up, the category 1 evidence, which is the highest level of evidence, which comes from the randomized trial, is for azacitidine in high-risk MDSs. You have lenalidomide and luspatercept in their subgroup, which I discussed. Telomerase inhibitor, imetelstat, is something which has come up recently, you would say, and I will discuss that in a bit. Category 2A is, there is lower level of evidence because we don't have RCTs, I would say, in good quality trials. But there is a consensus among the expert group. That is where our EPO or, some of these other regimens will come in. And what we have is category 2B, when you have mutation targeted therapy, whether you target the IDH1 or 2. With that background, I think the first 5 minutes I did dust out what is available in print, because it's not easy to deliver unless you, diagnose them and, prognosticate them and then understand where we stand. So this is one, scenario which confronts every hematologist, I would say, that is the pancytopenia, which I would say is one of the commonest presentation of MDSs. Some of us do get incidentally referred, for macrocytosis on a PBF, and then we, finally come down to MDS. But we must understand this term, because when you define pancytopenia, it is actually a decline in 2 or more cell lineages. And we must not get charmed by the entry criteria for aplastic anemia. The cutoffs are not a hemoglobin of less than 10 or a platelet of 50 or an ANC of 1500. That is for aplastic anemia. For pancytopenia, these cutoffs are 12 for a female and 13 for a male. You can have a cutoff with the TLC or an absolute neutrophil count. And platelet count, you see some guidelines talk about 1 lakh, some say 1.5 lakh. But there is also this term of persistent cytopenia as well, where the cutoffs are different. So you must understand, and we must be kind. As hematologists, sometimes, especially in academic centers, hard pressed for time, we get referrals left, right, center. We will have a GE physician referring a case of pancytopenia in the setting of hypersplenism, meaning we worked on what am I supposed to do? It's mostly so, but we must understand there are extra hematopoietic manifestations of MDSs and bone marrow failure syndrome. And you will see that on the extreme left in the first column, the referral can come from the endocrine, it can come from the chest OPD, it can come from the neurology, anywhere. So because you must complement that referral because you will unearth, some kind of inherited syndrome or an MDS in such a patient, okay? Because it's a broad differential. I borrowed this from, I thought there are some residents who are plugged in, and this is from the latest edition of Harrison. The table has not changed much, which classifies pancytopenia based on the marrow, because that's the heart of the question. And most of these answers are not answered by a peripheral blood smear. Sometimes you end up doing a marrow. And invariably, you classify the marrow as cellular, hypocellular, and maybe a combination of both. MDS comes in this subset of pancytopenia with a cellular marrow. And when I was reminiscing through what we end up seeing in PGI when I was doing my DM residency, whether be in the OPD or IPD, a large chunk of pancytopenia you could see either in the OP or IP would be simple CLD. That would be the commonest cause, and it doesn't require marrow, it only needs, clinical judgment. And you would see, but the ones which are highlighted in the red are something I would say core hematology, simple, trivial, treatable causes like megaloblastic anemia. And then, you need mandatory marrow for diagnosing aplastic anemia, myelodysplastic syndrome. And in the West, they have this idiopathic cytopenias or clonal cytopenia clinics, where you just are flagging actionable or unactionable mutation. So what would be the algorithm? So somebody with a persistent cytopenia history, clinical examination, to a great extent, would rule out nutritional and autoimmune and maybe an overt neoplastic processes. But if you have unexplained cytopenia at the end of a reasonable amount of history and clinical examination, the marrow is the way to go. And when you do a marrow, this is what I must say to each one of you who are listening, especially the the non-senior lot. When you plan a marrow, when you do an aspiration and a biopsy, it can't be redone, repeatedly, because biopsy is a painful procedure. At least most of us have done it umpteen times. You would know how painful it becomes, whatever you do. So you must take adequate samples, and these samples doesn't stop at just making a slide or an imprint smear. You have to have samples for cytogenetics, and then now the Pandora's box of the NGS panel. So when you have to decode them, you have to fit them into one of these groups, whether it is an idiopathic cytopenia of unknown significance. You come to this diagnosis when you don't have only somatic mutations, morphological dysplasia, and the marrow blast count is, preserved. It's less than 5%. Then comes the clonal hematopoiesis of indeterminate potential. That's a large group. 10 to 15% of people about 60 might have it. You might get somatic mutations, especially that of DNMT or epigenetic ones. But but there is no dysplasia which is morphologically obvious, and there is no increased blast. And then comes the CCUS and the MDSs, and that's where the difference lies. So the MDS, if you see the way, I would say when Agarwal sir would have started his career, he would have seen this unfolding in front of him. And then we are here at IPSS-M, and even there is a revised strategy for MDS now. So what has probably happened from an IPSS on the extreme left to the IPSS-M, which stands today, is the evolution. We are going beyond just evaluating cytopenias and transfusion dependence or morphology of the blast to cytogenetics and gene mutations. So has it refined our processes? Yes. And it's easy to calculate. This is an easy calculator. Anybody could use it with the kind of technology we have on our hands. We could easily calculate, and you can see these IPSS-M curves which separate out beautifully, which was not so obvious with the previous strategies. I would come back to this stratification. I would say when I was in PGI, I would remember Neelam ma'am, she was our HOD path, and she would say MDSs was one of the most difficult marrows to report, she would say. It's one of the most tricky marrows sometimes. So if you see, this is dyspoiesis is evident. On the extreme left, you are seeing dyspoiesis in the erythrocyte lineage. In the middle, you're seeing the granulopoietic dysplasia, and then this is the typical 5q deletion monolobated MEX, which you can see. We can see the ring sideroblasts in the lower left corner, and to the right, you can see all combined. So what is the problem with MDS diagnostics is there's something called inter-observer concordance. We saw in that risk stratification blast count percentage is of utmost importance because it can make a meaningful difference in the prognostication and even the kind of therapy you're going to plan for the patient. So this is a beautiful study which I think everyone must read. It's a law. It's an old study published 20 years, I would say 15 years ago in Hematologica. But this talks about this kappa statistic, which is actually the degree of agreement between two observers. It says when you have four cytomorphologists or hematopathologists reporting on MDS patients, 50 odd, the agreement is not much. So you can see even among the experienced or the trained eye, blast percentage reporting becomes difficult by morphology. When you talk beyond go morphology and you talk about cytogenetic, this is something which we must always read through the report. We end up sending this samples. I would always say send a marrow sample if possible. You actually see what is the meaningful data which is conveyed, because unless you have metaphases, which you can't actually comment on the quality of the cytogenetic report, Most of our cytogenetics would end up be reported as negative. If you don't, so importance of collection of sample, heparinized sample transportation, the reporting, and then, this is a sequential strategy where conventional karyotyping is opted first and then you move on to fish. We have moved on beyond that into, the NGSs, or I would say high throughput sequencing, and at the drop of the hat, we have clinical exome and exome sequencing offered at the drop of a cost of, I would say, 10 to 12,000, So it's not uncommon to find mutations in MDS because almost 80% will have some mutations, either in the epigenetics or in the spliceosome pathway or in the signaling molecules. But the flip side, unlike AML with MDSs, what I've seen is only a few like the IDH1 and 2 and the SF3B1 are really actionable in MDS. So to sum it up, morphology is the gold standard, I would say, because you must corroborate whatever the cytogenetics or even the molecular genetics throw up to you with the data junk which is emerging from these, whether it is NGS or high throughput. We must always have a good morphology. That's wherein I would say artificial intelligence, which I think is a discussion in every platform in hematology today, will have a role to play. There is a beautifully published paper in the myeloma realm from India a few days ago from AFMC, where they said AI added to a refined biopsy in a marrow and enables enumeration of plasma cell percentage better. The same holds true for MDSs. So the future workflow are going to be AI driven, whether it is diagnostic scoring and treatment, you can have a full discussion on that. So to sum it up, for having significant dysplasia, you must demonstrate dysplasia in more than 10% in any lineage. You would want cytopenias to be chronic, typically 2 to 4 months. I am not saying you wait for them, but it depends on the tempo of illness as well. If standard cytogenetics cannot be obtained, that is more than 20 metaphyses, that is where you would do either a fish panel or a chromosomal microarray. We end up ordering the fish panel more often than not. And reflex testing is something which is ideally to be done rather than sending everything at one go in academic centers, but sometimes not feasible. We end up sending all of them together. The percentage of blasts, which I said was very observer dependent, it is aspirates which have to be reported. You can use flow, but it is not, validated, and you must not substitute it for morphology. And in PNH, you must screen all our patients before you plan MDS treatment. So we have this classification, WHO 2022 and the ICC. I would say there is an ode to the chaos, because I think the group met a few months ago in Spain or Europe, and they are going to refine, this classification. There is a lot of overlap between ICC and WHO. We had to mug up all of these, or maybe for the pathologists, it was different. There were orphan entities as well. But I think we have a new classification coming up. But I would just want to warn the crowd here, even with IPSSM and maybe IPSSM evolved, the revised IPSS stands tall in 2026. I still believe the old wine is always useful, because although these, are very simple variables in IPSSR, where you use cytogenetics, blast, hemoglobin concentration, platelet, and neutrophil count, and you see the curves separate out into very low, intermediate, and high and all. Why is it important is, even today, most of the MDS trial results which you read are IPSS-R based. It is not IPSS-M. if you see the transplant algorithm, most of them are still IPSS-R based. I'm not talking about guidelines, they do talk about IPSS-M, but even clinical trials today go by IPSS or IPSS-R. So let's come back to the algorithm we just discussed. So it is not low risk MDS which we are talking about, it is lower risk MDS. And as I said, it is an IPSS-R of less than 3.5 or equal to 3.5 or an IPSS-M in some of the guidelines which have come. You are looking at, the cytopenias and you just want to improve them. That is what, and can you really prevent AML transformations? No, really we can't. So you are looking at for these evidences, you are looking at ring sideroblast in morphology or the SF3B1 mutation, because these are the patients where today you must be offering them luspatercept over EPO. When we have a del5q, that is where, and no ring sideroblast, lenalidomide is a game changer. In PGI, we had people of 15 years of len, doing exceptionally well with a little progression. But I just want to warn everyone here, when we label somebody as del5q, don't miss out the TP53 aberration by an NGS and a FISH, because these are the people who are not going to do well on len and they are actually higher risk and they are not to be given len and, chase level, but that's a very small subset. But in the large chunk of people who are non-del5q and no sideroblast, it is a choice between erythropoietin and luspatercept. And, there is evidence to say, which I will discuss, in 2026, if you ask me what is the evidence base for lower risk MDS, I would say there is data for erythropoietin, lenalidomide, luspatercept, and the telomerase inhibitor, imetelstat. A crowded slide, but what I want to warn here is the trials are all powered for some clinical outcomes. And if you read the second column where clinical outcomes are discussed, they talk about erythroid responses, transfusion independence for six months or maybe 1 year. They're not talking about an overall survival benefit. So that's not expected. But definitely, for a lower risk MDS, if you can keep him transfusion free, why not? So some of the, SF3B1 and the ring sideroblast MDSs have done exceptionally well with it. At least I have 5 patients with me, follow up for 3 years now. They've done very well. But I do know I have to follow them up and carry them because the cost adds up. Luspatercept is easily deliverable with few arthralgias. So how do I treat in my setting? Do I use the Nordic score, which talks about transfusion and the EPO levels to say whether EPO should be the way to go first? I don't chase EPO levels, but because most of the patients come after referral, heavily transfused, so the EPO levels may not be informative. But what I want, everyone to understand is, before you jump from ESA to something else, especially the costlier ones, you must put the patient on adequate doses of the erythropoietin. Whether you do Mircera or twice weekly standard erythropoietin, that's fine. But you must achieve a dose optimization, and you must do it for 3 to 6 months before we let go the EPO. Lenalidomide, as I said, is a game changer for 5q deletions and with no TP53 aberrations. Single agent, amazing data. Luspatercept, SP3B1, ring sideroblast, game changer. In the non-SF3B1, there is data now that it helps, especially in somebody whose EPO failed or somebody whose EPO levels at baseline are high. There is some minimal, anecdotal experience for hypoplastic MDS and immunosuppression with the triplet therapy. There is Chinese data for ATRA added on to danazol, ATRA added on to EPO. Danazol has been, a game changer for some of the people who are not so blessed. I move on to higher risk MDSs. This is where, transplant is going to be the game changer. So it's all about how do you arrange a patient for a transplant. The median age of a high risk MDS is close to 60-65, I would say. That is when most of the patients will not be eligible for a transplant. And that is when you have to, fast track, because there is a thought process that you look at the blast burden in the marrow, and then while you plan for transplant, you can give HMA. But at least in what we have managed, we would say that in somebody who is transplant eligible, if you try to bring the disease under control and take the patient for transplant, they progress very fast. So for some of those or most of the people in our country, our transplant rates for MDS will be, less than 1% of the eligible for various reasons, which may include resource constraint, financial constraint, center constraint, because we have a huge backlog of AML, THAL, aplastic transplants to do, leave aside MDSs. So if you see the evidence base for higher risk MDSs, beyond the transplant, there is a mountain of evidence for hypomethylating agent, whether it is azacitidine or decitabine. The earliest trial with azacitidine, gave an OS benefit that was not replicated, and that led to their approval. We have the oral decitabine and cedazuridine. Some of us don't have access to it, so no hands-on experience, at least with me. There is some data that in somebody who fails ASA or DES, or somebody who has an IDH1 mutation, there is some data of ivosidenib in the upfront and in the relapse refractory setting. This is a curve which I think each one of us would have been, this was a beautiful trial, the CAL-GB study on azacitidine, and you see the event-free survival curves, which has never been replicated ever again. The curve for azacitidine clearly, away from the supportive care arm. There was an ever-expanding graveyard for HMA-based therapy in high-risk MDSs. They tried to add everything possible under the sun, whether it was TPO, lenalidomide, magrolimab, the TP53 activators, and everything, I would say bites the dust. This is the latest from the JCO paper in 2026, where they try to add, the anti-CD47 signal magrolimab to the azacitidine, and it did not meet the primary endpoint, whether it is the overall survival or the event-free survival. You can see the curves overlapping each other. So that's what, what is sometimes shown up in the phase 1 doesn't show up in the phase 3. The same thing with venetoclax and azacitidine, promising data with good marrow CR with, azacitidine and venetoclax added to the high-risk MDS subsets. And, the median overall survival of 26 months. But what is the readout from the phase 3? It is only published as, I would say an abstract in the Clinical Leukemia Lymphoma Journal in November of 25. The phase 3 study of AZA-VEN did not meet the primary endpoint. You can see the VEN versus venetoclax plus AZA, the overall survival was 22 against 21. Obviously, the overall response rate was better. But I would say read out between the lines. Some of us do use AZA-VEN in some of the high-risk MDS subsets. That is to some extent based on this beautiful database. It's a validate database, large data sets of 1,500 odd patients, real-world evidence. And what does this real-world evidence show is the meaningful responses in the form of, I would say, composite CRs, which you can get when you add HMA and VEN. And it does, if you tease out the survival curves, the curves look overlapped, but if you tease out the TP53 wild type and those with lesser blast percentage, you would see that those with lesser blast percentage and the TP53 wild type does have an OS benefit. So how do I end up treating my higher risk MDSs? Not eligible for transplant, supportive care, quintessential part, transfusion support, chelation, EPO, TPO agonist, all that. I do a lot of azacitidine, decitabine till progression. I do a small subset azacitidine, venetoclax for patients who understand what it means. And now with the IDH1 inhibitor available, ivosidenib, I have been using it in some of my patients, both in the front line as well as in the relapse refractory setting. It's important, something which is not discussed in most of the academics would be the role of chelation if we talk about in MDS. So there is now a good systematic review because some of the MDSs, like 1/5 of the lower risk MDSs and almost 2/3 of the higher risk MDSs are transfusion dependent. And it has been shown in the beautiful blood review paper in 2025 that for every 500 nanogram per ml increase in ferritin, over 1,000, the OS significantly decrease. So for somebody who has an estimated life expectancy of more than 12 months, so whether it is lower risk MDS, if you have transfused more than 20 units of RBCs and the ferritin is more than 1,000, you must initiate chelation. And when it comes to transplant, you must balance it out and something like similar to thalassemia transplants, where chelation is a very important strategy. chelation becomes a very important strategy for high-risk MDSs. So having said that, I would say this is the only curative therapy for high-risk MDS even today. So the search for that elusive donor has always been a problem. Only one third of our actually eligible patients, fit patients for of high-risk MDSs have a donor who is matched sibling or matched relative. MUD, I would say the uptake is far too less than again under 10%, 20%. So that means you have to do a lot of haplo transplants, at least in the two of the transplants which we did in the last 6 months. One was a match sibling donor. I still remember a young lady from Rajasthan, transfusion dependent. I would say high risk MDS. As I got some transfusion independence. We did a match sibling donor transplant, typical flu trio conditioning, because we don't want to lose a patient to TRM there. And now she's 2 years into transplant. I would say no, I would say, yeah, that, and then she's doing well. The haplo transplant, which is, I would say, about 3 months or post transplant, that was a haplo donor. The donor was the son himself for a 58-year-old, otherwise fit patient. As a failure, we gave as a while we are arranging all the logistics for the transplant. We did the PTCY platform for haplo. Luckily, not much of GVHT, but we want some GVHT because that's the way forward, and that will take care of the MDS as well. So I don't wait for cytoreduction. At least when the blast percentage is less than 10%, I take up the patient directly for a transplant. For a fit patient, myeloablative would be the way to go. But for an unfit patient, RIC conditioning would be a way to go. So I would say this is the evidence based when you talk about allogenic transplant in MDS. That's the only potentially curative treatment. With an HLA match donor, it is a level 1A recommendation. And if you see in most of the registries, whether it is the European or the American registry, you will see the 3-year overall survival is 50%. Haplo is a suitable option, lacking an HLA match, 2C evidence, and you will see the 3-year overall survival drops. MAT is the way to go in a fit. RIC is an alternative. But because we don't want to lose out the patient, there are so many variables which will affect the transplant outcome. My last few slides, the allo transplant in a low risk MDS, because we said transplant is going to be the panacea for MDS patients. And that is when, even low risk patients, some groups took them up for a transplant. 112 subset, a paper which was published this year in January in Blood Advances. Although they would divide them, or define them as lower risk, you would see as per the revised IPSS, some of these were higher risk and with this kind of cytopenias they had. And what did they show? If you see, the NRM was 25%. That's a large chunk. And, the overall survival curves relatively overlapping and not statistically significant, clearly telling us it's not prime time for allotransplant for the lower risk MDSs. That's what I would want to say. It's not easy transplanting everyone and curing most of it. To conclude, that's where I would say I would get to the ugly side of MDS management. So this is what the evolution of medical knowledge in MDS. We did talk about the classification, the refinement and the prognostics, the availability of agents from the vintage EPO to azacitidine to decitabine, and then the oral combination of decitabine, cedazuridine, the ivosidenib, and then the transplant outcomes refined over a period. But for all these to reach out to patients in our country, beer hugs alone won't do. We need to get the stats right. This is what I like about them. They have this kind of data. You just see the AML data set. Just for an example, it is like this. SEER registry says 22,000 cases of AML. That's the counting they do. They count every single transplant. So they count. That's what we want to know when we do MDS management in our country. We are actually setting the birth and death registration in order. It's now digitized and it's mandatory. So, from registration of births and deaths to getting into the statistics of MDS, it's a huge wish list. So this is my wish list, which I keep sharing across all the platforms, whether it is MDS or AML. We need to collaborate and mine as much data to have consensus guidelines and compliance amongst us, because it can't be my way or highway or eminence-based medicine. We need to standardize. At the drop of the hat, we order from private firms, NGSs and MRD. How much are they standardized? what is the quality checks, how are they evolving, all of them. And some of these drugs must reach, the essential drug list, which needs to be revised more often. Most of these drugs, will now are in the, generic, and that's the way forward for us with clinical trials can come to our country as well, and that is how things will improve. So for the MDS care train, is it the flagging of moment, because this is a dream come true, but this was just the first hydrogen power train which was flagged by our Prime Minister a few days ago. For the MDS care train to be flagging off, I think a lot needs to be done. And that's I would say, the uglier side of it. With that, I would conclude, and I would be happy to take on any questions if they are there. Thank you everyone for the patient listening, and thank you MHG and Dr. Gawal sir in particular for giving a very junior faculty an opportunity to connect with a larger crowd and put across the points. Thank you, sir.
Thank you, Arun. Very modest in calling yourself as junior faculty. You are now our very senior colleague, and we are learning from you. It was a beautiful talk. Enjoyed listening to you. So we'll have questions from our colleagues and from the audience in the chat box. Do you use lenalidomide anytime in a case of refractory anemia due to MDS without deletion 5q?
So, sir, I have done that at least, and that data I would share with the PGI subset. We did analyze our data where pushed across the wall, we had azacitidine failure or EPO failure, and we have given lenalidomide. It works. It works in 2/3 of the patient. 1/3 of them become transfusion independent, fairly long periods. Even 5-year data we have. It works, but how does it work? It's a lot of mechanisms which are explained, but it's a very good cheap available generic formulation, and it really works. And for the person, it's because a very low dose, we don't have to do 25, even a 5 milligram or a 10 milligram works, and even twice weekly doses work. So it really works, sir. Like danazol, it has worked for some of our patients even without 5q deletion. Completely agree with you, sir. It has worked.
Sure. Any questions, please? And when you are giving lenalidomide and the hemoglobin, say, becomes 14, and it is staying at 14, so what is your next step?
So we had at least in the armed forces where we capture follow-up data. So at least I can narrate my own experience with 2 or 3 patients who have done so beautifully well with Len, even in the 5q subset. The biggest problem with Len, was the second primary malignancy, which was always a concern. And there is data set in the myeloma realm that the secondary malignancy is a concern with continuous lenalidomide exposure. So I always discuss when somebody hits that 13 and 14 mark. But there are patients who really don't want to get away from that because it has given them a good quality of life. For somebody who's tolerating, I have not stopped Len. I have come down on the duration, the intensity, sir. So from daily to twice weekly to even weekly Len I have done. 10 days of Len in a month I have done. But to take off the drug, it's a difficult proposition. Sometimes patients don't agree. Although you discuss the complication of especially the secondary malignancies with long duration lenalidomide. So it's a equipoise. So there are 50% patients who don't want to let go Len and are continuing with Len even though they have hit the transfusion independent and hemoglobin threshold targets of 14 and 15. At least 2 to 3 patients are doing well, but it doesn't jump beyond that. So it is, I would say, informed decision making there. Patients agree to the risk, then we continue. But we don't do daily. We have come down to 10 days a month or even, twice a week. It has worked beautifully for those patients. Sir.
Thank you. Amit, your question.
Hi. Any young patient who is low risk MDS, any role of upfront transplant where you will go for upfront transplant for low risk young fit patient?
So if you ask me, like I did present the evidence to that in the last few slides. If you go by the evidence base, that was a blood advanced paper in 2025. Lower risk MDS, the NRM was 25%. The overall survival with 3 years was no different from the supportive arm. But having said that, for a patient, it's a decision making because the NRM is purely, I would say, a transplant center's data. So finally, how many evolve and and you have to see see through a younger patient who is lower risk for many, many years, the allotransplant has always been a curative. So if I get a matched sibling donor, and I know it is a lower risk, but there are some cytopenias which are, requiring some kind of intervention, maybe 1 or 2 hour transfusion. They are not by book fitting into the transfusion dependent because they don't require more than 2 units a month. All that criteria being met, it's a decision. I wouldn't do a transplant. That's if you ask me a personal question for a lower risk MDS, just because of the sheer data which is available, which says the NRM is fairly high and they can be managed better in the non-transplant setting as well. I wouldn't do. Evidence base is also not for a transplant in all lower risk MDSs. But there are some MDSs which I discussed with you who have cytopenias, which by book doesn't fit into a higher risk MDS, but they are requiring transfusions, rare blood groups, sensitization has happened. They are not willing for continuous transfusions. They are the subsets where I would say, or a bad fulminant infection because neutrophil count just dropped for a transient period, near life death experiences. That is where I would discuss, transplant as an option. If they are willing for that NRM risk and a matched sibling donor is available, I would take that patient up for a transplant. So it's a purely shared decision making. That's what I would say.
Thank you. Regarding MDS with fibrosis, young fit patient, will you offer transplant who is heavily transplant dependent? Young fit, say for example, 40-45 years patient who is a MDS with fibrosis, heavily transfusion dependent, no NGS shows no mutations. And
Yeah. So transfusion dependent MDS, 45-year-old fibrosis. Yes, marrow has to be, we'll have to, I would say, give him a better marrow and a microenvironment. That patient, yes, in a fit patient with a matched sibling donor, I would definitely go with a MUD. I would go in for a transplant. With the haplo, long-term data is not good. The 5-year survival is around 30%. He is ready to take it. Why not? Why not give it a try? Yes.
Thank you.
Thank you.
Any other question? Gopinathan.
Good evening, sir. This is just a live case that I saw today. So this was a 63-year-old female, actually basically evaluated for myeloma. She had M band of just 2.3, marrow showing 10% plasma cells. Occasionally, when she was actually not fulfilling a full slim crab criteria. The marrow plasma cell was just 11% with some mature plasma cells. Calcium was normal, creatinine was normal. The only point is hemoglobin was 9.6. This what it comes is the karyotype done for myeloma fish panel also has detected 5q deletion. So now how common is this 5q deletion when it is being done for when the fish panel is done for multiple myeloma? And now in this case, since she's not fulfilling a slim crab criteria, how will we react to this 5q deletion?
Okay, I'll give my answer, but I think Agarwal sir can also help us out. But because we have seen more than what both of us combined must have seen. But to me, if you ask, like we don't treat 5q deletion report on a fish. I always said marrow dysplasia is of utmost importance. I would look at marrow clearly. I would comment on the plasma cell percentage with a caveat here. The plasma cell percentage on an aspirate is always, because of patchy involvement, you may not quantify them adequately. You must quantify using biopsy, and maybe an IHC would also help. I disagree in a bit because you said the hemoglobin is 9.6. So I think the crab criteria would be met, I would say. So just having a 5q deletion with not a morphological equivalent, I would not, and maybe if you are giving VRD, Len as such is part of the regimen. So either ways it should help. But I would always say morphological MDS with a 5q would be, MDS-like picture. We have had, even in the Vexer syndrome, a few MDS-like picture in the marrow, a 5q deletion shown up. There are 5q deletions even in normal population, about, I would say 10%, but that doesn't mean they are MDSs. We must look into the morphology and then, take a conscious decision here. Plasma cell percentage interpretation, we must be very careful when we just rely on an aspiration. If you have done a whole body PET or a whole body MRI, you must have excluded the lytic lesions conclusively. The age I forgot, it is a young patient or a old patient
She's a
that I put
63-year-old female, sir.
63. So it's difficult to make out whether it is and SIF is IgG or non-IgG.
This is it's IgG kappa.
Yeah. So IgG kappa, very difficult to make out whether it is an IgG kappa MGUS with FIQ del low risk MDS. So these are the questions which needs to be answered. So look at the marrow more appropriately. That is what I would say. If it is dysplasia predominant, it is IgG kappa MGUS with or a smoldering myeloma with 5Q MDS. If it is plasmacytosis, which is obvious, and minimal dysplasia, I would label it as just a clonal 5Q, but that needs evaluation subsequently.
The same in the same sequence. I have doubts. Just I was thinking if the 5Q deletion only is 12% of the cell study, won't it take some time to morphological changes to get evident, because the pathologist clearly has written it is normoblastic maturation in erythropoiesis. Not in marrow environment, marrow microenvironment also is okay. Not much of any inflammatory environment that she had commented. The morphological changes are not that evident. So, and hemoglobin is 9.6. So that's why which side to incline in this patient is what.
Yeah, Gopinan, I'll just add here the typical morphology, the phenotype of a 5Q is a middle-aged lady with thrombocytosis, with monolobated megakaryocytes in the marrow. That's the typical morphology, right? So unless we have a typical morphology, just having a 5Q fish on a 10-12% cells, because there is a lot of immune microenvironment mediated clearances of these clones also. We have seen it happening. I've seen MDS is labeled as 5Q, and when you do marrow subsequently send fish, the clone has been deleted. Just even on on observation. So how much we should take cognizance of that, like what you said, we can probably follow it. We don't have to just bell the cat that just 5Q comes up and then MDS, and then I would not do. I would rather observe. Yeah, like what you said. Yeah.
Actually, I put her on observation, sir, as you were telling. Just put her on observation. Maybe I think Q3 monthly follow-up should.
Yeah.
Gopinathan, two questions about this. What was the MCV and what was the platelet count?
Yeah, MCV is actually 89, sir. MCV is 89. Platelet count is bang normal. It was 1.57 lakhs. There's no thrombocytosis.
And as Arun asked about the megakaryocyte morphology, any comments by the pathologist?
They have commented typical normal trilineage, like a trilineage hematopoiesis, sir. I mean, no dyspoiesis per se.
Megakaryocytes are normal in morphology.
Yes, sir. Yeah.
Yeah. And you must have ruled out all other treatable causes of anemia, right?
Yes, sir. Yes, sir. So that is after physician had initially seen her for some months' time, and then only she had come to us.
All right. And so if you are very confident of having ruled out myeloma, creatinine clearance, PET scan, as Arun suggested, all those things have sort of confirmed that this is a small M-band, and serum free light chain assay, creatinine clearance, PET scan, bone marrow aspiration, biopsy, everything is sort of against myeloma. Then from the practical angle, in favor of patient, I would probably treat the patient with lenalidomide, see what the efficacy is, because that's something easily treatable. Myeloma can wait to evolve. When it becomes frank, we can go for the myeloma, because if you try to hit this case as myeloma, then there is no end to it. You'll have to continue the treatment. And it also depends upon, as you said, you wait and watch, because 9 gram is not bad. She is probably asymptomatic. What did she come to you for?
She actually came to me for fatigue, sir.
Fatigue. A symptom. Okay.
Yeah.
Yeah. Sure.
Fatigue and non-recovering hemoglobin. That's 9.6. The lowest didn't cross even 9.5. So that's why I'm just thinking, can we just observe for some time?
Probably you can easily. When she's educated and going to follow up regularly, then why not?
So
The question in the chat box, high risk MDS, hypocellular marrow, cytopenia, patient is intolerant to EZA. What will you do? I'm not mentioned whether transplant fit or not.
Yeah, thanks for the question. So when you have a higher risk MDS, that is what I would understand. And you have, if in a, like what Agarwal sir was saying, if it is a transplant fit patient, that is the way to go. That's the only curative treatment I would say. But if the patient is transplant ineligible, or maybe for whatever reason we can't offer a transplant and is not tolerating as a, definitely we must look into any actionable mutations. That is where you can have an IDH1 or an IDH2, they are targetable. And now we have good 2 to 3 year data sets where they have done well, they have become transfusion independent, and they can really do well on these single agent therapy because they promote differentiation. Cytopenia is resolved, they become transfusion independent. So I would say look for actionable mutations. That is what I would say. When you have a hypoplastic MDS, that is the another thing which I must want you to discuss, because there is an entity of hypoplastic MDS, and that is where you must use these modified de Bono or Bono criteria. And when you have those entity, because they are very much sensitive to immunomodulation, so they do well on ATG and cyclosporin, and you can add even a triple therapy to such patients when even an elderly would tolerate that kind of a therapy. So you must see whether this is a hypoplastic MDS, which would merit, who would merit, and ASA is not the way forward for them. There's usually an immunomodulation, which is the way forward for them. But if it is a transplant eligible patient, I think it's a no-brainer. We must be taking up this patient for a transplant.
Yeah. So both this question and the question asked by Amit Khurana, I'll just add one sentence that within the prognostic classification, when you apply the molecular one, within the lower risk and within the higher risk, there are very low risk, intermediate, low risk, high risk, very high risk, intermediate, high risk. So the prognosis of, say, Amit Khurana's patient, very low risk, can be median survival of 10 years. In that case, you will not venture with transplant with knowing that somewhere somebody will be lost, somebody will get graft versus host disease. And same thing about this high risk MDS, if it is very high risk, etc., then you will come what may, try your best for transplanting. But if it is a intermediate high risk with hypocellular, as Arun said, immunomodulation may be good. So it's a lot of clinical judgment, and I think there's a lot of weightage in the classification, which you have to see that what is the median survival of this patient, exactly applying the molecular prognostic scoring. It helps because it gives you confidence that, okay, this is a bad case, this is a good case. 2 minutes left. Any more questions? Okay, so thank you so much, Arun, for the beautiful the question answer session. I'll just share my slide deck again to introduce Dr. Neeta. So Dr. Neeta is additional professor, HOD, Department of Pediatric Hematology Oncology at Postgraduate Institute of Child Health, Noida. She is a leading pediatric hematologist oncologist in India with over 25 years of clinical and academic experience. She is widely recognized for her leadership in improving childhood cancer care and hematological outcomes, both nationally and internationally. She is chair of the IPA Working Group on Childhood Cancer, executive board member of CIOP Asia, honorary secretary of the IAP PHO chapter, holds an MBBS from Trivandrum Medical College, MD in Pediatrics, and FNB in Pediatric Hematology Oncology from Sir Gangaram Hospital. She was named Precision Hemato-Oncologist of the Year in 2025 and recipient of the CIOP My Child Matters grant. She will speak to us today on chronic ITP in pediatrics. So over to her.
Sir, I hope my slides are visible and
Yes.
audio is clear.
Yes.
Good evening to all. I would like to thank Professor M.B. Agarwal for this opportunity. I've been asked to speak on chronic ITP with a from a pediatric perspective. So before I come to chronic ITP per se, immune thrombocytopenia is a very common condition in children. It's basically an interplay between immune-mediated platelet destruction and impaired platelet production. And over the years, we have realized that this whole immune-mediated platelet destruction is not just a simple antigen-antibody reaction. There are many more immune pathways in action. And this understanding has helped us realize that there may be more targeted treatment opportunities that are available, and many of them have already been tested in adults, and few of them have found to have been approved in pediatrics as well. So over the years, immune thrombocytopenia, we all know that the acronym has changed from thrombocytopenic purpura to thrombocytopenia because purpura per se is not required, and platelet count of 1 lakh or 100,000 is the diagnostic threshold now. I'm just repeating it for the trainees in the group because a lot of parents come with, whenever there is a platelet count of say 1.2 or 1.3 lakhs also, there's a lot of anxiety at times. So we generally counsel them and not evaluate further unless it is consistently trending downwards. And from the earlier discussion on primary, secondary, and acute and chronic, etc., now it has changed to newly diagnosed persistent and chronic ITP. Newly diagnosed between 0 to 3 months, and from the onset of symptoms, 3 months onwards, 3 to 12 months is persistent ITP, and 12 months onwards it is now chronic ITP. Then there's also a terminology. So these are all again very standard terminologies which have been there after a lot of consensus guidelines. So this one, what I am quoting, is from the Vicenza guidelines, which were published in 2009. So severe ITP is bleeding symptoms which are there at diagnosis or later, which is mandating either a new treatment or addition of increasing a dose or addition of a new agent, which is there. We also, when we discuss chronic ITP, we should understand what are the standard response assessment that is used by many of the trials. Most of the trials now adhere to these standard terminologies. The quality of response is similar, as in the terminologies are similar. But definitely, this is very important when you're comparing two different drugs, or when even for your patient, when you want to see whether there is an evidence to add a new agent, or it's a requirement to add a treatment at all. All of this becomes handy. So complete response is when we have gone back to more than 100,000. Any response is more than 30,000. And the time to take from 0 to this response or complete response is the time to response that's taken. And so this again is a terminology which is used in trials. No response is whatever you've done, platelet still remains less than 30K. And loss of response is when you have had a response and it is coming down, or a less than twofold increase from the baseline. So how many children actually go into chronicity? So there are large registry data which is available, which has shown that with or without treatment, around 12 months plus, that is when our chronic ITP, which what we are discussing today, around 20% of patients eventually develop chronicity. So this is again something which we upfront tell our parents that whether we treat or we don't treat, 20% will have low platelets beyond 1 year from diagnosis, and only 80% will remain off drug. So it's again nice to tell them in the beginning, because many a times when there are expensive treatment options being discussed, like for example IVIG or L-Thrombopac, they should know that whatever we do, still 20% will remain chronic. And in that chronic group of patients, which is more than 12 months, 7% only will have platelets which are less than 20K. So this is again something good about pediatric ITP, that not many are going to be less than 20K, not many are going to be symptomatic. So you may not require treatment in the first place. So although platelets are low, it is basically an understanding between the family and us that we are going to keep the child under follow-up and not and selectively watch and wait and watch and not really act on every platelet count. And usually acute ITP presents with all this, that newly diagnosed is a very, very anxious time for the doctor and the parent and the patient. Like often the patient is not as anxious as the others in the team. Now, chronicity does not mean it is a failure of therapy. So this is the statement which came from Voltaire long back, that the art of medicine is just to amuse the patient while the nature takes care of the disease. This is very, very true in chronic ITP. So here we are just waiting for it to go into spontaneous remission naturally. And this is the norm in pediatric ITP. So because of which we just keep the child under follow-up, explain the lifestyle modifications which are required, and then just keep the child under follow-up. So every platelet count need not be chased. As long as the patient has not bleeding too much, the patient has a decent quality of life, lifestyle and activity, whatever restrictions we can advise, as in from like prevention of head injury, avoidance of NSAIDs, etc., we do tell them. As long as that is taken care of and the patient is otherwise having a decent quality of life, that is enough, and we may not have to escalate treatment too much. How can we predict? From a clinical association point of view, these were the things which were discussed very early on, like many around decades ago. These predictors of chronicity came in, and even after like 2 decades, I think we are similar. We are in a similar boat even now. We don't really have great biomarkers to predict whether the patient who is coming to you today with a platelet count of 10K is going to remain chronic or not. So basically, the dictum is to treat the child and not the count. And when most of the treatment that we offer will not change the natural history of the disease. And what can change the natural history? Possibly one is splenectomy, and the other is, now it has been they discussed whether TPO receptor agonist can actually alter the natural history of these patients. So we'll see the etiopathogenesis in a brief before we come to see how it is being targeted in treatment. So loss of immune tolerance, we all know that there is basically an antigenic mimicry, and then there are cells which are autoreactive. There is autoreactive B cells and T cells, and these are going to kill the platelets. So mostly it is directed against B cells. So usual treatment is these autoreactive B cells are the most troublesome ones. So that is how the steroid, IVIG, all of this treatment came into being. But in addition to this, there is defective T cells in the form of cytotoxic T cells per se that would kill the platelets, as you would see in, let's say, a stronger autoimmune condition. For example, a patient where there is a T cell directed killing, or it can be definitely in many other, as in many other autoimmune conditions, T regulatory cells may be low. As a result, it fails to suppress this whole autoreactive process. So that's the most simple explanation. In addition, there are this autoantibodies which are released by the B cells. Definitely that results in this platelet specific autoantibodies remain for a long time. So even if we take care of the B cell per se, this plasma cell which produces these platelet specific autoantibodies may contain, and that's why many of our treatment options usually fail because autoantibodies keep getting produced despite whatever treatment we are offering. Then direct platelet injury by the cytotoxic T cells, either directly to the platelet or to the megakaryocyte, both have been demonstrated. So here again, treatment should be directed against the T cells. And finally, the whole concept of thrombopoietin agonist, how does it work? So TPO is being produced by the liver, and it acts on the megakaryocyte through the CMPL receptor, and there is a cytokine signaling further down. And here it has been found that unlike in conditions like, for example, aplastic anemia, where your TPO levels would be markedly elevated, here in ITP, the TPO level is not that great. So there is a possibility that if you stimulate this receptor, if you provide receptor agonist, that can actually improve the downstream signaling, and that can actually improve the platelet production. So it can, this receptor agonist has been found, and then I think it's been almost 10 years since they have been in action, and they have been found, and they have almost replaced, even the treatment algorithms have changed in pediatric ITP also because of that. So most of these patients who, when ITP starts off, it's mostly this 80% patients who are going to be self-limiting. This whole autoimmune process will remit by itself. There will be a restoration of the normal immune system, I would say. Immune surveillance cells come into place. That's contraction of the autoreactive T and B cells, and finally recovery of platelet count. So the antibodies are no longer in circulation. So this the concept that there are antibodies and these antibodies remain in circulation for a long time have to be counseled to the family. But whenever you're taking up as in treatment, for many a times, many centers would probably start on IVIG, and then the patient responds the second day, third day, the response comes in. And after if everybody is happy, the child gets discharged. A week, 10 days later, or maybe 2 to 3 weeks later, the platelets fall again. That's because once the half-life of IVIG comes down, because the antibodies are still there in the circulation, it continues to destroy the platelets. So this concept has to be told to the family that these antibodies will remain for a long time. As long as it's stable, as long as platelets are okay in an okay range, we would not treat. And just because we've given a very expensive treatment does not mean that it is going to be better or it's going to be more effective than the other agents that we have. It's just will give you a earlier, quicker, a better response initially, but it need not be sustained. So chronicity happens when there is persistence of autoimmunity. So there's persistence of B or T cells. There is an epitope spreading, because of which more and more autoimmune clones are produced. The T regulatory dysfunction continues. There is a persistent antigenemia. So in a lot of rheumatological conditions, that antigenemia is continuing, and that is actually triggering the immune response. So unless you control that, you may not be able to control the disease per se. And these are all responsible for persistence of the disease, and we need to target each one of them, and only then we'll get a sustained response. So this is epitope spreading. A lot of times, I'm not sure whether I haven't found any evidence to that, but many times we tell, we generally discourage platelet transfusion whenever, even if the patient comes with a platelet count of less than 10K, as long as there is no real significant bleeding, a mucosal bleeding, we generally discourage platelet transfusions, saying that you are exposing to more and more platelet antigens. I'm not sure whether actually that is true, but the thing is that whenever there is platelet destruction, there is additional damage, additional release of new platelet antigens, and probably this autoreactivity increases. You are now sensitive to many more antigens in the platelet, and that's probably one reason that this autoimmunity persists. The spleen becomes an immune hub, and there are multiple mechanisms in the spleen. So again, new agents which are targeting not just rituximab, many more other agents which will target the receptor-mediated phagocytosis, or patients actually reduce the splenic function per se in order to improve the autoimmunity. Immune tolerance, we can again target it in many ways. And finally, antibody-independent mechanisms, which are either TPO or T cells. So whatever be the biology behind it, ultimately we have a low platelets. But if we are able to understand this biology in some way, if we are able to understand it, or if we are able to predict this biology, we'll probably be able to manage these children much better than we are managing them currently. So even in those patients who have entered that chronic ITP phase, so 20% from the onset, 50% of those children will also go into remission. So ultimately, very few patients are going to persist as chronic ITP to 2 years onwards. So that again is going to be, this is also a decision-making thing in coming to the management perspective. And there are long registry data which also supports this, that very few patients actually continue being thrombocytopenic, and some do, and there are patients who have been thrombocytopenic for 10, 15 years and so on. And it becomes difficult, but it's kind of a lifestyle modification that sets in, and the family also understand how to manage these patients. When we counsel them, we also need to know what are the numbers in terms of what are the numbers of patients who will bleed significantly, probably less than 10%. And when we say significant bleeding, it is either grade 3 or grade 4 bleeding as per the usual WHO classification of bleeding. And IC bleeding is very few percentage of patients have, and it's a long series where there's 40 intracranial bleeds in ITP patients. And here again, only 30% had chronic ITP. So the estimated incidence is less than 1% of ITP. That it is good to have some kind of grading system to follow. We generally follow this system of grades of bleeding, grades 1 to 4, to decide whether we need to see. So essentially, if you have mucosal bleeding, or if you have any severe bleeding, you definitely end up treating them. But petechiae bruises per se, you don't need to treat them. Another classification is the SMOG bleeding assessment tool, where skin, mucosa, and organs also can be, again, similar kind of grading, but that's also something nice to follow, just to know where you are in your treatment or where you are in the disease, natural history, and so on. So ultimately, from the beginning, only 5 to 2%, 5 to 10% ultimately, as in from chronic ITP onset, they would require actual treatment to improve platelet count. So from the beginning, if you see, it is probably just 2 out of 100 that actually finally require some platelet treatment. And whenever you reach that chronic ITP stage, that is, you are 12 months from the diagnosis, we need to actually sit down and reconsider whether this is chronic ITP or is there something more. So initially, in the earlier days, we used to evaluate mainly for rheumatological conditions and infections per se. But now there is a lot of focus on immune deficiencies as well as immune dysregulations. So that is also that comes in your treatment evaluation algorithm, probably earlier than even 12 months. So many times, if it is a child with 6 months of bleeds, as in somebody who has gone into persistent after 3 months, if you have evidence, you may even evaluate them early. So marrow failure is something which, again, like conditions like Fanconi, etc., will present only with thrombocytopenia in the beginning, and many a times these children get misdiagnosed as immune thrombocytopenia. And later in the course, like another 2 or 3 years down the lane, maybe there are features of other cytopenia setting, MCV being high, etc. So if you have not done a marrow earlier enough, it is probably worthwhile to do it currently. Rheumatological conditions, definitely. And then again, not many patients would have any of these positive. So if you do not have anything positive, and if all your other workup is negative, it is worthwhile to do this as an annual process. Many times we see the children become, like 2 or 3 years down the lane, they become ANA positive. And another 2 or 3 years down the lane, they'll have other features of lupus coming in. So this is all an evolving, a kind of a diathesis in process. So it might be, if you have something like an ANA probably coming up, now a lot of rheumatologists even start them on disease-modifying agents early enough, even if they do not fulfill the criteria. Infections, definitely, not so much now, but definitely these are evaluations that we do. H. pylori used to be popular earlier, now not so much. EBV is another infection, especially if it's a boy, because there are a lot of immune deficient disorders where there is EBV viremia, persistent chronic EBV viremia with thrombocytopenia. And finally, in the immunodeficiency subset, we would look for both lymphoid immune deficiencies, lymphoproliferations, and immune dysregulation. So here, CVID, XLA, definitely. So an immunoglobulin profile and subsets would be helpful. ALPS, if you have evidence like chronic lymphoproliferation evidence, BCP positive, definitely you will evaluate for ALPS. And immune dysregulation, many times it is difficult to suspect it as such because other than ITP, you may not have others. But if you have, like if you have patients who present with another phenotype, for example, a patient who comes with an nephritis, a patient who comes with a diarrhea, an inflammatory bowel disease kind of presentation, growth affected, patients who have recurrent episodes of fever, so and so. So definitely evaluation for immune dysregulation is worthwhile. And here again, screening tests are very few. So it's probably worthwhile to get an NGS at this point of time. A boy with thrombocytopenia, even on day 1, you would look at the NPV. Now, I don't wait for chronicity actually to set in. But many a times, it may not have other features of Viscott. So Viscott, again, is a spectrum. So patients who have, on the other end of the spectrum, that is on the XLT side of the spectrum, they may have only thrombocytopenia. So if you're low MPV, then definitely worthwhile getting again them evaluated. Here again, sometimes you may require a genetic test and genetic setting testing directly to get to a diagnosis because the other tests may not be available, like flow cytometry may not be available in many centers. Now, how do we manage them? So landscape has actually changed over the last 2 years. Initially, historically, we used to treat them with steroid, repeated courses of IVIG, DEXA, multiple courses of DEXA, and a lot of immunosuppressants. So azathioprine, cyclosporin, etc. used to be popular in those times. So those children actually used to look like our renal patients. Like by the time they are like 4 or 5 years into the treatment, you cannot differentiate between a nephrotic syndrome patient and a chronic ITP. It used to be very bad. Now, thankfully, all these agents, most of these immunosuppressive agents, the traditional immunosuppressants are out. So now you have better agents to deal with, better agents to use and lesser side effects to deal with. So here again, a lot of family education, like in most chronic diseases that we deal with, a lot of parent education, patient education is required. So first, from day 1, we'd counsel them not to chase platelet counts. Infections. So any patient who is stable at 30, 40,000, any viral infection comes in, your platelets would drop to 10K. So that should not create panic. We classically give the example that my platelet would be 2 lakhs. If I have a viral fever, it becomes 1.5 lakh. I'll never get to know because I don't have symptoms. But your child who has a platelet of 50K, it may come down to 10K. Do not worry, it will pick up after a while. So unless there is any symptom, you do not actually work on that particular drop because of a viral infection. Activity restrictions, definitely. So although we say intracranial bleeding is less than 1%, we have to be very, very sure that they do not hit their head. So helmets while on the ground, and they should be told to tell the parent in case they have a head injury. So I lost a girl around, I think 10, 12 years ago with a chronic ATP who was perfectly stable, who had a cricket ball injury to her head, and she did not tell her parents. 3 days later, she had altered sensorium, and by the time she was taken to a hospital nearby, it was too late. So although we say IC bleed risk is very less, but still these are conditions where these things can happen. Then again, NSAIDs. Lot of pediatricians, orthopedicians, all of them use NSAIDs very frequently in their practice for fever, pain, etc. So this again has to be told. The written instruction sheet is nice. Oral hygiene, like for any other condition where there is thrombocytopenia, good oral hygiene, constipation. Try all epistaxis, constipation, rectal bleed, etc. Very common sites of bleed in children. So that should be prevented. Then the second problem happens in adolescents during menstruation. Generally, 20, 30,000 are also okay till the time they have their first period. So here again, they will bleed. And at times they'll bleed so badly that you end up having to give a lot of many treatment. But here again, we must understand that it's going to be a chronic process. We are not going to change by just giving steroid or IVIG, it's not going to improve. So try other means, like a lot of patients are put on noritestosterone as well as Tranexa, and they generally remain stable on that. So you don't have to treat the ITP, you just treat the bleed part of it. Report symptoms and evaluate annually. So even if there are no other symptoms, an annual evaluation
Something happened. She got left out.
He hasn't joined back quite some time now. Maybe power failure or something.
No, she may not be knowing that she has got disconnected.
No, that she must have realized. But it is quite some time she hasn't joined back. Maybe we can see for another 2 minutes. Meanwhile, anybody over here wants to discuss anything in between yourself or with Dr. Amit or me? Questions, experience, comments?
So I would just like to share. This is Dr. Aishwarya speaking.
Yes, yes.
I recently had one patient in my OPD. She was diagnosed at 8 years of age with ITP, and she's been on several, like seen many people, but finally recently only, and then they switched to Ayurveda. They used to go to Chandigarh to get that Ayurvedic medicine and all, but still her platelets, they never went up to beyond 50-60,000. So now I just started her on L-Thrombopec 50, and like it has worked beautifully. Platelet is 1,75,000. It's holding past 2.5 months. So the thing is, how long do I continue? And like I do plan to maybe after 5-6 months to bring it down to 25, and then just try to stop and see. But like, is there any direction or any other experience on this?
So Aishwarya, L-Thrombopag and TPO-RA in general are now the first line of therapy of choice in chronic ITP. That's number one. Number two, your goal has to be very modest in chronic ITP. Any count above 30,000 is good enough. So don't have to aim too high. Number three, your L-Thrombopag dose will be totally guided by the platelet count. So if you got a platelet count of 30, 40, 30, 40 with 50 mg, I'll make it 50, 25, 50, 25, see over a month. And if it can maintain again above 30,000, I'll make it 50 alternate day. So we just keep tapering as per the response. Sometimes there is a real problem. Someday patient count is 20,000, someday it is 1 million. So those are very tough cases really where you have to do very frequent count and find out a dose where you don't have such fluctuation. But goal is just to have a count between 30 to 50,000 rather than aim too high. And lastly, it's only about, I would say 15 to 20% of patients who are cured by L-Thrombopag. Most of the chronic ITP patients, 80% plus, have to remain on long-term L-Thrombopag. When I say long-term, it is lifelong. So that has to be taken for granted. You have to tell the patient that this is a long-term therapy. Only 1 out of 10 or at the most 2 out of 10 can come out of it. So rather than experimenting stoppage, creating a situation where platelet crashes to 0 or 2,000, again starting all over again, it is best to just titrate the dose and keep the count around 30, 40, 50,000. I don't think she's joining back. Amit may be right. She may be still giving the lecture. Possible. So we call it a day.
I think, should we do a WhatsApp call to her once? Then she will realize that.
Let me check whether I have easy access to her number. I don't have her number on my cell phone at least.
I may be having just.
Right.
Yeah, I will call her.
Yeah, please.
Yeah, she's joining.
Good.
Dr. Amit, really sorry. Can you hear me?
We can hear you. Go ahead.
I'm really sorry, sir. This has never happened before. To this extent, it has never happened before. So,
Go ahead. Yes.
From the patient education program, last slide was that.
yeah. Just a second. Hello?
Yes. Yeah.
Hold on. Somehow there's an internet outage. I was not able to connect. So I'm coming back to the slide. My audio is clear, right?
Yeah.
Yeah.
Yeah. So this is opened on Keynote. I'm not sure how to do full screen. I'm trying to manage with this for now. So is this clear? Can you see the screen?
Yes.
Sorry, yes, sir. Sorry, Dr. Aman.
Yes.
So this is what we'll advise. So not to chase platelet counts. Every infection, there will be a fall in platelet count. So not to worry too much about it. A lot of activity restrictions. A head injury should be prevented at any cost. And if there is an injury to the head, the family should report to the hospital so that we can evaluate in due time. Oral hygiene is important. Preventing constipation, menstrual bleeding, etc. again becomes important. So now coming to consensus management, there's no real consensus in as far as chronic ITP is considered. Only things which are what we are consider important is that we need to treat grade 3, grade 4 bleeds only. Many a times, if there is a fall in platelet count, we do give steroid, like in an acute ITP or in newly diagnosed ITP, you do give rescue treatment. But after that, maintenance treatment is essentially now TPO-RA, receptor agonist, and there were many other options. We'll see one by one. Now, steroids in chronic ITP. Short courses of steroids definitely may be required whenever there is a loss of response or sustainable response is lost, probably for 5 days or 7 days, not more than that. Life-threatening bleeds, definitely IVIG plus steroid plus platelet, etc. may be required. And repeated courses or long-term courses of steroids are completely out to be avoided in patients, in children especially, because of long-term ophthalmic toxicity, bony morbidity, etc. IVIG, again, there's no role of chronic maintenance with IVIG. It is only for rescue treatment that we give. IV anti-D used to be popular earlier, but now we do not use it at all. But partially because it's not as effective as IVIG, not as available, and a third, finally, because of hemolysis that can accompany. Now, under second-line agents, this is probably the grading, as in you would use TPO-RA as the first line now among the next level of treatment. Rituximab, whenever you need we're not getting a response and you need to add on to it. And finally, splenectomy, although the guidelines still keep splenectomy as one option, probably because it's one treatment that alters the natural history, but it is coming down and down in the algorithm as every year advances. Now, TPO-RA, we have already discussed how it works. There are 3 drugs which are available under this: eltrombopag, Romi, and avatrombopag. We'll see how they are. They generally work like Romi works through the extracellular domain of CMPL, whereas eltrombopag and avatrombopag works through the transmembrane domain. Eltrombopag has a lot of oral administration related issues, whereas avatrombopag definitely generally does not have any issues pertaining to the food as well as the minerals, etc. Interaction with food, minerals, etc. is much less in that. So whichever way the mechanism of action is, it results in, it shows improvement in platelet counts. And many times you could even add both of them together as well. And they do not have any, the baseline TPO level, that actually does not have any role, as in it will work despite the baseline TPO levels in these patients. So the pediatric data came in very early from the PETIT trials, which showed here, all of these trials used 50K as their cutoff to show improvement. And here again, between PETIT 1, PETIT 2, and between eltrombopag, Romi, as well as the next agent, avatrombopag, generally responses are in terms of similar, around 60-70% patients would respond. So overall, the odds ratio to response is around 4:1. When we consider patients per se, there are a lot of conditions, a lot of adverse events that you need to be worried about when you are starting eltrombopag. But generally, over the years, we've seen that it is safer. It is safe. We can increase doses. So we generally start in younger children at 25 milligrams per day, and then you can go up on the dose. Maximum generally in pediatric population, you give up to around 75. Initially, when it was started itself, it was realized that East Asian population has higher systemic exposure, so maybe lower doses work. Doses often tapered to the response, and objectively, we need a platelet response of around at least 30-40,000, but in the study, it is 50K. Hepatotoxicity is a concern, so we would not give in a patient with liver dysfunction, and we also would watch for transaminitis. Thrombocytosis, thrombosis, these were again concerns, but long-term data remains well. Initially, myelofibrosis was a concern. When it came in at that time, there was a practice of even doing bone marrow at that point of time to see whether there is any fibrosis in the marrow, but then it also is not a big deal. What is a big deal is that drug interaction. So because a lot of these children may be on calcium, or they may be having iron deficiency, they may be on iron, etc., or antacid because of steroids and so on. All of this can reduce the GI absorption. So this is something which we need to teach our families properly, that they need to have any between meals, there should be a 2-hour gap. And especially in a meal, in a child would probably have calcium or milk containing, dairy containing products. So there should be a 4-hour gap. So a good window to give it is around 7 in the morning, because you've been fasting overnight, and you take some small meal in the morning, and 7 you take the drug, as in you take it along with the juice or something like that, and then avoid food for another, any dairy, calcium, iron, etc., for the next 4 hours. The other window which is often helpful is around 6 p.m. There again, you would between 2 p.m. to around 9, 10 o'clock, you have a gap, and that again you can avoid these dairy products at that time. Milk can be given in the morning and so on. So this lifestyle advice has to be given to the families, and many a times non-responsiveness is because of these interactions as well. So that also has to be taken into consideration before you think of changing the drug or increasing the dose of the drug. Now, other than PETIT 1, which was shown earlier, then came the phase 3 RCT, which was the PETIT 2 trial. Here again, chronic ITP patients 1 to 17 years, prior splenectomized, few of them. Again, similar data that they showed sustained response above 50K, and around 40% patients did respond. And this was again achieved in the study trial open label extension also. There were patients who at least reached 50K during couple of times during their treatment. Now, what has happened recently is that although this is not chronic ITP per se, there is a move towards using L-Thrombopag early in the treatment. So even newly diagnosed patients were put on L-Thrombopag, and they found that patients by the end of 8 weeks, sustained platelet response was much better than the standard of care that was offered to the patients. And this came out last year in JAMA. And almost 30% difference between L-Thrombopag started at baseline versus the standard of care, which should have been steroid or IVIG, etc. So this again is an interesting space to watch out for. And probably we are thinking of patients, the disease being modified by L-Thrombopag per se. So whether it will actually improve the natural history. So this again, if you start early, whether it will give a sustained remission later is something which we need to wait and see. Romi came in almost at the same time as L-Thrombopag, starts at 1 mic per kg per week for a pediatric patient. It goes up to 10 mic per kg per week. And again, similar data, 50% all will have a platelet response of above 50K. And even when it is extended also, over the years, patients showed that good response, even at a median dose of around 6 mics per kg per week. And the last agent which came out and again recently published was Avatrombopag, orally bioavailable, lesser dietary restrictions. Site is the same as L-Thrombopag and does not compete with endogenous TPO. And again, around 30% patients responded here as well. And if you look at durable response above 50K, that was around 28%, whereas patients above proportion of patients with any platelet response, that was above 80%. L-Thrombopag versus Romi, there is not much difference. Adverse events are also not very, it's generally tolerated well, both of these agents. So one versus the other, it would be basically cost and having to give an injectable once a week. So these are all considerations you will have when you will counsel for one drug versus the other. Not much difference in terms of response. In real world data also, among all the TPO-RA agonists, so almost multiple studies, multiple pool data per se also showed that the response over the year, above 50K response, initial platelet response was almost similar in L-Thrombopag versus Romi. So this again, there is no real reason to choose one over the other. Now, what is new is there is a concept of sustained remission, as in treatment-free responses have been noted in patients. So here, modification of natural history, possibly by an immunomodulatory role or change in the T regulatory activity. These are all ways of ways how they propose that it could be helping. So around 20% patients in trials have been shown to be, as an after when you taper and stop also, they continue to be in remission. So is it the original disease actually having in natural course having a remission, or is it a drug related modulatory effect? We do not know, but this is something which is now tried. So patients who have had a good response, in whom low stable dose has been found to be effective and have a sustained response for long periods, no significant bleeding, no need for rescue therapy, etc., may be considered now for tapering. Switching between one agent to other, one agent fails does not mean the other agent should fail. So it is not a class drug. It is basically both of them act through slightly different mechanisms. So you may consider changing, especially with L-Thrombopag, because there could be dietary interactions, liver disease, liver dysfunction, etc. In which case you may consider changing the agent or maybe adding on the agent to see how it is responding. Earlier, splenectomy was being offered. Even now, in guidelines, splenectomy continues to be there. Splenectomy in pediatric population, as in splenectomy all over, has undergone, as in is not preferred at all. But and over the years in pediatric population also, long-term side effects like thrombosis, pulmonary hypertension, etc., have been identified, and because of which we are not doing splenectomy for most of our patients. Guidelines still continue to mention it, but temporarily it is coming down. Splenectomy definitely works, and splenectomy can work in some patients who do not have access to these drugs or are not able to follow up regularly and so on. But on the flip side is splenectomy has a lifelong infection risk. So that is again, it is not small. You still lose patients to splenectomy, as in splenectomized patients 5 years, 10 years down the lane also comes back with an infection. At times you may not be able to save them. So these are issues which should be considered, and so it is no longer discouraged. Again, no longer encouraged. And splenectomy again, when you offer it as a treatment, it is not a foolproof treatment. Here again, after removing the spleen, the liver can take over the function, and liver can actually continue to destroy platelets. So that is one reason why there is failure of splenectomy. Another reason is the other mechanisms. It's not a spleen-related mechanism. It could be megakaryocytes being less produced, or patients having a T cell destruction, etc. All of this can be contributing. So here splenectomy, there's no way to predict that splenectomy may work and opt that as a treatment. As of now, there are no biomarkers to prove that. So these are all the side effects by which it is not this thing. And even I think long-term data on adults who underwent splenectomy also, there is some cancer risk also which has been noted to occur in patients. So these are all reasons why we do not opt it anymore. The other second line agent is rituximab. Here again, very, very popular earlier, but now with TPORAs, it has come down. Rituximab doses are standard. Many patients, many centers offer lower doses and follow the B cell counts and see whether you need to give more and so on. Overall, it works definitely, but it does not work for all of them. And it may not work if you have long-lived plasma cells which continue to produce autoantibodies, or if there is other mechanisms of destruction. So initially, rituximab initial response may be around 40 to 50%, but over the years, after initial response is achieved, also platelets may fall, and around long-term, as in 5 years from rituximab, probably around 20% of patients will continue to have good platelet counts or sustained remission. So that is the issue. So here again, a drug with a lot of toxicity, a lot of conditions you have to worry, but ultimately you're getting only around 20% patients who have a sustained response. The response median time to response is around 12 months. And in pediatric per se, when you start, you will always rule out an underlying immune deficiency before starting rituximab, because you need to know whether you are doing this for a CVID patient or you're actually creating an immune deficiency after. Like if the IgG levels don't improve after a few months or a year from the rituximab, then you tend to worry. This has happened many times. We tend to worry whether this was a CVID to start off with, or is this just taking time to respond. Adverse events, definitely hypogamma, infections, and PMLE. So all of this is counsel to the families before we start. If at all we are offering rituximab in a chronic ITP patient, this is again now very less. There was a meta-analysis again a couple of years ago, which looked at TPORA versus rituximab. So see whether there is any, one is preferred over the other. As far as the primary endpoint of 50K was considered, it was similar. Whereas secondary endpoints, definitely higher rates of rescue therapy in patients who had rituximab. So that was again TPORA scores there better. And generally lesser serious adverse effects with TPORA compared to patients who receive rituximab. And over the years, sustained response also is better for TPORA compared to rituximab. The traditional immunosuppression is almost out. It's very, very rarely we use cyclosporin or azathioprine. Once in a while, sirolimus still comes in place, and dapsone definitely. So dapsone is like it is an immunomodulatory agent which works in around 30% of patients. There is data from low and middle income countries. There's data from India which has shown that it works. And we, like as my center, we use it very regularly because many families cannot afford TPORA. So here, at least now, there are more generic products available. But earlier, when it was not at all an option, dapsone used to be our next treatment after if you're switching to a second line. Things we need to remember is to look for G6PD deficiency because it can really cause hemolysis in patients, children who are G6PD deficient. And second is many patients can have a rash, Stevens-Johnson, etc. That also we need to counsel that anything, if there is a problem, come back. And dapsone causes a little bit of hemolysis, whatever said and done. So hemoglobin actually drops by 1 gram or so in patients. So many times when you start and like they will come back to you and tell us that in the morning there is a little darkening of urine, and hemoglobin also, like from 10 it becomes 9 and so on. Nothing very dramatic, but these are things you watch out when you are putting the child on dapsone. But again, dapsone low dose, 1 to 2 milligram per kg is the dose, and it continues for a long time so that your response is sustained. And when you have a sustained response, you can take it off, but many times on taking it off, the platelets also fall. So these are the agents which can be added on, like MMF, sirolimus, and cyclosporin, when you have to add on to the immunosuppression to work more on the T cells. And this again, lot of toxicity, I'm not going into it, but definitely may be required for few of our patients. So our earlier strategy used to be repeated courses of steroid, IVIG, multiple anti-immunosuppressions, then IV, and then probably at that point splenectomy and so on. This was like around 25-30 years ago. But now it's just rescue drugs, say straight away TPO receptor agonist. And if there is no response, that is a very, very small proportion of patients, they may require other immunosuppressants or rituximab at that point of time. And now there are a lot of new agents, now a lot of targeted agents that have come in ITP. We'll see some of them. So most of this has come in adult practice, as an adult data has come in, pediatric data is awaited. So you can target spleen tyrosine kinase, that is SYK. You can target BTK, you can target neonatal FC receptors, you can target complement pathways, you can target plasma cells directly. But which patient, whom, what to target is that information we do not really have right now. And so that you can choose between the drugs. So even now, it is kind of a, you can just put one drug, trial and error kind of scenario where you will see and then look for a response and then move on to another agent if required. So coming to fostamatinib, which is basically working on the spleen tyrosine kinase. Here, when you target, so you're coming back to the receptor. Once the FC receptor, the antigen antibody, the autoantibody coated platelet is coming to the FC receptor in the spleen, the downstream signaling is through this SYK. And if you target it by this tyrosine kinase inhibitor, so here definitely, unlike steroids, it's a targeted treatment. So steroid also works by reducing the splenic function, autoantibody production in the spleen, as well as even these receptors are downgraded. But unlike that, this is more of a targeted treatment. There is adult data, but unlike in tyrosine kinase inhibitor, there is growth issues with this drug, so it is not yet approved in pediatric patients. But again, if you look at response, it seems to be okay. And safety-wise also, in an adult population, it is not so bad. So this is the last paper which came out, Lopez et al. In 24, and it shows that it is one of the options which we can have. Now, BTK inhibition, it works in 2 different pathways. So one is BTK, which works on the B cells per se. So I'm not able to show it here with the pointer, but in the second panel, you can see that in B cells, the B cell receptor signaling is through a BTK, and here the drug works here. And second, the B cell, when the macrophage takes in the antibody mediated, the antibody coated platelets, here again, BTK comes in way. So it is basically cause and consequence. B cell receptor signaling, it reduces autoantibody production, and FC receptor signaling in the macrophages or effector cells, it reduces the killing of the antibody. So it works in both ways. And here again, 50K is the primary outcome, and 65% achieved an outcome in the adults phase 3 trials. There are some patients above 12 years who were there in the trial, and this is a space we need to watch for, where I think it would require, which it would receive a pediatric approval soon. BAFF-R inhibition is another monoclonal antibody which is targeting the BAFF receptor. Here again, phase 3 adult data has come out recently, which looks at ianalumab, which is a drug which, along with eltrombopag, it has been found to show decent response. Again, around 60% response has been shown. So this is something where a combination of this monoclonal antibody with TPO-RA is something which seems to be promising. Again, not yet in pediatric population. Neonatal FC receptor inhibition. Here, the antibodies are not taken up by the FC receptor, so they return to the circulation and then they get degraded quickly. So as a result, so that antibody, because it gets degraded, platelet counts improve. And this is again advanced trial which came out again a couple of years ago in adults with primary ITP. And here again, relatively like IVIG, it works similar to that. Quick response you would get, not yet approved in pediatrics. Daratumumab is something which has pediatric data now. And here it is CD38 targeting. It occurs the rituximab failure when we talked about CD20 inhibition. A lot of patients fail it because you have long-lived plasma cells who do not express CD20. So plasma cells continue to produce the antiplatelet antibodies. So here when you target it with daratumumab, they have been shown to be responsive. So this paper again came out last year, which looked at 20 children with refractory ITP. Here again, median time to response was 1 week and 18 responded out of the 20 patients there. And 20 patients, 17 had rituximab failure. So that was that bad a cohort. And out of that, 18 patients responded. So this is something which seems to be interested. So here the response seems to be good, but how long the response will continue and so on, that is something we need to, the duration of response is something that we need to look at. So, but it's a well-tolerated drug, effective therapeutic option for patients who have very bad, as in refractory relapsed ITP, where there is a bleeding phenotype, we are forced to give something and your usual agents have failed. This seems to be good. And finally, among the new drugs that have come in, CAR T-cell, as for in many refractory autoimmune disorders, this has been now shown to be effective in immune thrombocytopenia also. It eliminates the CD19 B cells in circulation, so reduces autoimmunity. And it has been used in refractory ITP. So it was presented as a poster in this year's ASH. 4 eligible patients were there. And after the usual lymphodepletion, the autologous CD19 CAR was infused and resulted in B cell depletion. And B cell depletion, so that autoreactive clone of B cells also came down and it showed response. The good things are that median patients these 4 patients who were there had a median of at least 4 prior therapies and all had received IVIG, TPO-RA, etc. and still did not respond. And these patients, 3 out of 4 had a good response to this treatment. So very, very expensive way of dealing with it, but still this is something that you could consider. ATRA showed some response in adults. So ATRA with rituximab, ATRA with dexamethasone, ATRA has immunomodulatory role. So it may help restore impaired thrombopoiesis. There is no established pediatric role as of now. So in the years to come, it is predicted that we'll be able to know the endotype of the disease. We will know what actually is driving ITP in that particular patient. It need not be only B cell mediated disease. It may be multiple other ways of mechanisms which are involved. And if we have a way to know which is what, then we may be able to select our agent more smartly and early, so that we get a safe level which is okay for the family and which may not alter the disease mechanism, natural history, but still we'll be able to have a symptom-free patient. Chronic refractory ITP is either ITP after having, as in failure of splenectomy, or 2 other agents. Here again, multiple agents have been tried. Nothing new in that spectrum. It's essentially combination drugs. And if you identify immune dysregulation as part of your workup, now there are targeted treatments there, like LRBA, there is abatacept, and CTLA4 haploinsufficiency, there is abatacept. So again, these agents can be, they help in immune cytopenias, whether it is AIHA, whether it is ITP, and it would help in lymphoproliferation, etc. as well. But again, long treatment, almost lifelong treatment for these patients. And you will have to additionally, when you add many of these agents, there may be infectious risks that you need to look into. Can we predict chronicity? The original prediction, which came in out of a meta-analysis in 2014, that's what we still go by. There is nothing new. As in older age, female sex, patients who have an insidious platelet count, insidious course and not very low platelets, all of these are going to become chronic. Biomarkers, there have been work on antiplatelet antibodies, immature platelet fraction, whether it can predict chronicity, TPO levels, whether it can predict chronicity, T-cell cytokine markers. So every now and then there is a paper which looks at a particular cytokine signature and tells that this predicts it, but nothing which has actually translated to a use or a guideline till now. And definitely, if you have an underlying condition like an immune disorder or a rheumatological condition, definitely that predicts, but otherwise there is none of the immune signatures currently are validated for routine clinical use. So we actually will not know when the child comes to you, whether this child is going to respond. Majority would respond to IVIG, but whether that response is sustained, whether any of our agents, like which TPO array to choose, whether TPO array will produce sustained response, whether rituximab will give durable remission, all of these answers currently we do not have any evidence to base our decision on. So this has to be explained to the family when we started. The other good thing is a lot of ITP, the treatment is not decided just by this. There may be patients who are living with 10, 15K platelets, but have a very decent quality of life. To decide the burden of disease is something which has come up as in over the years, over multiple trials also, whether any new agent coming in, whether the trial actually whether the drug, although it improves platelet counts, does it actually translate to a better quality of life is something that we need to see. So things we do not usually keep in mind, like fatigue is something we generally do not qualify. In a pediatric patient, it becomes very difficult to even define what is fatigue and to quantify what is fatigue. Restrictions on physical activity, sport, menorrhagia, these are all issues which come up in a pediatric patient when you treat them. So this burden probably also will be a decision maker for us when we treat. And there are pediatric specific quality of life tools for ITP. So this has been validated. And here again, child's response, how the parent perceives that the child is having an issue, and parents' own burden of the disease or parents' own impact of what my child is having this, and because of which, what am I feeling? So those are three different questionnaires, and this has been used in many trials and validated across both acute and chronic ITP and tested in TPO era as well. And so even though TPO actually, so in one of the earlier petty trials when this was used, although drug-wise it is all working well, but the questionnaire did not actually show much of a significant change in terms of what the child perceives. So even if there is a response for the child, there was not much of improvement as such. So and probably the next decade, research priorities would be to predict chronicity at diagnosis. So that's something which would be really, really helpful for all of us. Whether early therapy. So this again, there was some work earlier that early IVIG probably results in better reduced chronicity, but that did not really prove much. But if now we need to watch that space, whether early TPO array will actually improve, change the natural history and modify the disease course. Is there the whole concept of treatment-free remission will come up in TPO array also. So that is something we'll have criteria to decide when to stop. Can we identify which type of ITP is this? Among the ITPs, this is T-mediated, this is megakaryocyte-mediated. That kind of identification with some biomarker would be really helpful. And which biomarker can predict which biomarker can predict which treatment to use and treatment response, can it predict it? What are the long-term impact of TPO array? I think by now we already have around 10, 12 years of data. And finally, the treatment, whether it is actually measuring the improvement for the child. So I would conclude, I'm really, really sorry for all the technical glitch. I will conclude by saying that we have moved a long way from platelet count, managing platelet counts to managing the child. a lot of counseling definitely goes in, and it is very difficult to counsel a family. It's one of the, as in, it's much easier to counsel probably malignancies and other conditions where you know a definitive course is there. ITP is one of those conditions that are extremely anxious families. So it's that kind of trust has to be built from the beginning. From broad immunosuppressions, we have moved on to safer drugs and probably more targeted treatment coming on. And finally, from empirical testing to more precise management. So I'll stop here. I'll be happy to take any questions. Thank you.
Thank you so much. Lovely talk. A few questions in the chat box. In a newly diagnosed patient of ITP, you prefer steroids or L-Trombopac?
For newly diagnosed ITP, if we decide to treat, the decision is between steroid versus IVIG now. Earlier, it used to be anti-D also, but now IV anti-D is not available as much. So it's basically steroid versus IVIG for a newly diagnosed ITP. As of now, L-Trombopac is not in the treatment armamentarium for the first 3 months. We would start thinking about it from a persistent ITP point of view. But that paper is a very nice one. I've seen a lot of physicians add a TPA agonist from the first week onwards as well. But as of now, I haven't seen data to prove that. But this is something probably which will come in the coming years.
Other question is, in a chronic refractory ITP where everything has failed and you're planning for splenectomy, how do you prepare the patient for splenectomy when the platelet count is negligible?
So the good thing about splenectomy is that the platelets generally improve while the patient, just as soon as the splenic artery is clamped, and the platelets generally improve. So the whole preparation goes in the earlier part of it. So if it's a really bad patient, you're preparing for splenectomy, definitely do all the vaccinations, keep the patient ready, all the evaluations, everything should be complete. And under SDP cover and under steroid cover, you will take up the patient. So there will be some response, and definitely as in you will get the platelet to above 50K at the time of GA when it is being induced. But usually, if it has to respond to if the platelet responds to splenectomy, usually as soon as the splenic, the pedicle is ligated, as soon as that, you will start seeing a response, and the post-op period may not be as difficult to manage. Then there is a whole discussion around laparoscopic splenectomy and stuff like that, which also have been, as in people say, open versus laparoscopy. Laparoscopy might be easier and so on. All that are discussions which you used to have in the past. Nowadays, hardly ever is splenectomy is done.
Thank you. Any question from the people present here? Okay, in that case, Dr. Neeta, thank you very much.
I'm really sorry, sir, for the, but I think we finished.
Yeah. And thanks to Intas for supporting it, and thanks for Perfect Square for managing it. So good night to everybody. Okay, bye-bye.
Thank you. Thank you. Bye.